way that we really have enacted medical aid in dying in the United States, apart from Montana, is through state statutes. There's two ways to enact a state statute. You could do it through a ballot initiative, or you can do it through legislation. So in terms of ballot initiatives, all these blue states have a ballot initiative or proposition process. And we tried that in the late 80s and early 90s without success. So we had ballot initiatives to legalize medical aid in dying that didn't get passed. And the problem actually with those ballot initiatives was they were written to legalize both euthanasia and medical aid in dying. Right? So medical aid in dying requires self-ingestion. The patient takes the final overt act. And so it was thought that that was the reason those ballot initiatives failed, is because they were going too broad. So in 1994, Oregon puts another ballot initiative up for a vote, and that time it gets passed. Now it ends up in the courts for a few years, and actually they do another ballot initiative for exactly the same thing, and the voters actually pass it again by an even wider margin. So medical aid in dying starts in Oregon, and it has a very solid patient safety record for year after year after year. And based on that, the Oregon model is followed by other states. So in terms of ballot initiatives, followed by Washington, followed by Colorado. And there were some other close calls in Maine and Massachusetts, and some other states have been considering ballot initiatives as well. In terms of legislation, the Oregon model was followed through a legislative approach in Vermont, in California, in Washington, D.C., in Hawaii, in New Jersey, in Maine, and this year in New Mexico. So altogether, we've enacted 3 statutes through initiatives and 3 through bills. So as of today, November 9th, 2021, we have 11 jurisdictions where medical aid in dying has been affirmatively authorized, right? And people say that medical aid in dying is available to 1 in 5 Americans because they add up the population of those 11 states and divide it by the total U.S. population. And the efforts are ongoing. More than half of the remaining states consider bills every session. But the new bills are different than the old bills. There used to be a commercial by Oldsmobile, because I guess they redesigned it, and they said, "This is not your father's Oldsmobile, right? This is new, this is different, this is better." Well, we might say that this is not your father's made bill. For 25 years, between 1994, when you have the November ballot in Oregon, until 2019, pretty much everything had focused on that original Oregon model, right? And that model was followed in Washington, right? In California, in Colorado. And we might call that MAID 1.0, right? The initial model. But there's a move now, and there has been a move to sort of break that mold, that mold from Oregon, and to focus on access. In other words, looking beyond just making it legal instead of being illegal, right? That sort of binary approach, and looking a little bit closer at under what terms and conditions is it available, as opposed to just making it legal or not. In other words, the question is getting asked more, can the patient actually get it? Can they actually get that prescription? And so that's what I want to turn to, and I'm going to call that MAID 2.0 and MAID 3.0, right? So in terms of MAID 2.0, there are a couple developments. One is changing who exactly is a qualified clinician, and second, changing the waiting period. So in terms of qualified clinicians, the traditional rule, the Oregon model, has required that your eligibility, meaning you have capacity, you understand this option, you have a terminal prognosis, your eligibility is confirmed by both an attending and by a consulting physician. But that traditionally has required that both of those clinicians be a physician, meaning that it's an MD or a DO. The problem with that, as we know, is there's a shortage of physicians in many, many states. By limiting it, the qualified clinicians to physicians, it makes it more difficult to access medical aid in dying. So the response has been to extend the qualified clinicians to nurse practitioners and to physician assistants. It's worth noting for context that almost every state that has pulsed, which is most states, allows them to sign a pulsed order. In terms of expanding to APRNs and PAs, that's already happened in New Mexico and a fair number of states. I didn't list them all, but a fair number of states have bills to do the same thing. In terms of the waiting period, the traditional rule has required a 15-day waiting period. So the patient has to make at least 2 oral requests, and they have to be separated by 15 days. 17 days in Vermont, 20 days in Hawaii. And the idea is to assure that the request is enduring, that the patient is really reflected upon and thought about this carefully. not acting from impulse. But we know that that length of a waiting period constitutes an undue burden. We now have evidence to demonstrate that. People can't wait that long. During that waiting period process, a lot of people are going to lose decision-making capacity or die. So the response has been what? Waive it, for at least for the subcategory of patients that can't wait that long, or to shorten it for everybody. We've already done that in 3 states. So Oregon, California, and New Mexico have waived or shortened the waiting period, and a fair number of bills in other states seek to do the same thing. So that's MAID 2.0. I want to turn to MAID 3.0. This is what's coming up next. This hasn't happened yet. So this focuses on residency and on the self-administration requirement. So in terms of residency, the traditional rule has been that every state's law says, in addition to be terminally ill and having decision-making capacity, you have to be a resident of that state. The California End of Life Option Act is only available to Californians. But just to take this as an example, if you look where Portland, Oregon is, it's right near the Washington state border, right? So there are people that live on the Washington side of that border who get their health care because it's the closest hospital or clinic available. They get their health care in Portland, Oregon. And this physician who works at OHSU in Portland, right, has Washington state patients, and some of whom would like medical aid in dying, but he can't help them because he's an Oregon doctor, but the patients are Washington state residents, not Oregon state residents. So he brought a lawsuit just days ago arguing that Oregon can't do this, right? Oregon cannot limit medical aid in dying to Oregonians, which is what the law does. And he says it because it's unconstitutional and it violates what we call the Privileges and Immunities Clause of the U.S. Constitution, which says that the citizens of each state shall be entitled to all the privileges and immunities of citizens in the several states. So you can't discriminate against non-Oregonians. And then finally, the self-administration requirement. The traditional rule has been that the patient can ask and receive a prescription drug that then they may self-administer to hasten their death. And of course, at least a full third of patients don't even do that. So they may self-administer. And the drug, the dominant drug, we now call DMAPH. But the key point here is that the patient alone is supposed to take that final overt act. There's 3 different ways you could do it. Generally, people would drink it. So you would take the drug and mix it with something like apple juice and drink it, or use a straw, or you could press a plunger on a feeding tube, or you could press a plunger on a rectal tube. Now, other people, third parties, may help the patient prepare the medication, prepare the rectal tube, prepare the feeding tube, mix it in the cup, but they may not help the patient administer the meds to cause the drugs to go from outside to inside her body. But what about ALS, for example, and some other neurological diseases? In the late stages of something like ALS, the patient is going to be paralyzed in a significant way and may therefore be unable to self-administer, to push the button or to hold the cup or to use a straw. And so the lawsuit in California, brought by some patients with ALS and other neurological diseases in federal court in California, argues that the End of Life Option Act, to the extent it requires that nobody else can help the patient who needs help, violates the Americans with Disabilities Act because it discriminates against those people otherwise qualified for the End of Life Option Act, but who just happen to be physically unable to self-administer the medication. That's what we might call MAID 3.0. So then, as of today, we have 11 jurisdictions that permit medical aid in dying, but also it's not just that there will be more jurisdictions, but that the new laws, the laws of tomorrow, will make medical aid in dying more accessible to terminally ill patients, both in terms of eligibility and in terms of the procedures that they need to follow. Thank you.